Welcome to this edition of the Pharmacy Innovators Podcast. I'm your host, Jim Jorgensen, and today our guest on the show is the Chief Pharmacy Officer at a 1,200-bed multi-hospital health system in Oregon and Southwest Washington, Dr. Majid Tanas. Welcome, Majid.
Thanks for having me, Jim.
Absolutely. For our listeners that don't already know you, can you start out and give us some background on, what you do now and how you got there?
Sure. So I am a Chief Pharmacy Officer, Vice President for Pharmacy Services here in the Portland area in Northwest Oregon and also in Southwest Washington, where we have a total of 8 hospitals around the metro area. We also have about 100 clinics that are also include primary and specialty clinics within the area as well. We have a department roughly of about 500 people that help facilitate our patient care, and we are a 340B program with a specialty pharmacy and a couple of joint ventures for some other venues that we have within our market. My road here has been somewhat of an interesting road. I did my residency as a HPSAL resident up at University of Washington in the Seattle area. Came down to an academic medical center down here in Oregon, where I spent about 7 years working in the outpatient realm, specifically looking at ambulatory infusion centers, outpatient pharmacy, specialty pharmacy, including research pharmacy, OR, and some inpatient duties before moving to the East Coast, where I was the chief of pharmacy for the National Institutes of Health Clinical Center. There helped remediate 483 that they had received from the FDA and had worked a long time with them to try to get their practice standards up to where the rest of the country had been with regards to USP. After about 4 years, they determined it was time to come back to the Northwest. This is where home is, and have been here for the past 4 years.
Great. I think your time at the NIH Clinical Center, that must have been very interesting. How would you compare the overall practice of what you did there with what you do now?
Yeah, having the privilege of working in academic, research oriented, and then a federal research organization, and then in community hospitals, each practice area has had very different standards and different practice directives or value that they place. I think with the NIH, one of the things that we spent a lot of time doing was to help bring specifically the USP standards and the clean rooms up to specifications. It's always hard when you're in a place of remediation. You have to move quickly, especially when you have regulators who are constantly looking over your shoulder, making sure that you're doing things right. And I think it created for a pretty unique situation to learn in, to grow in, to be able to help that facility move forward. I think it also highlighted just how easy it is for complacency or the normalcy of bad practices, where a lot of times we were asked, well, why do we have to change these practices? Why do we have to change that? And I think from that experience, one of the things that I've learned in my career is to really have a very clear why statement. We all know the Cotter's principles of change and creating a sense of urgency as being one of the first steps. And I think that without really having that very clear urgency or that clear why, I think it's sometimes hard to really move a department forward, period, basically. And so I think it really just created an environment that had to be fast-paced. Practice is definitely different on the different coasts, and so it was a very interesting mix of challenges and learnings to be able to help lead that team.
Yeah, I couldn't agree more. That what's in it for them is always crucial if you're going to get any change initiative moving forward. No matter how good the change is, it's generally never sought after or welcome.
Absolutely. That's absolutely true.
I think, kind of watching your career advancement, from my perspective, I think wherever you've practiced, you've always been very passionate about redefining how and where we practice pharmacy. And, can you give us a few examples of areas that I think you've seen success in and where leaders should be thinking, particularly in terms of more patient-centric care?
Yeah, that's a great question, Jim. I think in my realm, one of the things that I tend to hone in on is when leaders at an organization will say, "Well, that's how it's always been done, and so we're going to keep doing it that way." For me, I tend to ask the question, well, why is it that we've always done that way? If there's a good reason, let's keep that going. I think the challenge that we face today in modern healthcare is that our why statement really needs to move from the inpatient side to encompassing the whole patient experience. And so, to your point, I think a large part of my career has been centered on helping patients bridge that gap between the inpatient and the outpatient world. I think when health system leaders specifically look at outsourcing some of these services, I think it's really a missed opportunity. One of the great ways that I've been challenged in my thinking to consider this is if somebody's willing to do it for you, there's probably some revenue there that you might be missing. So a great example with that with outpatient clinics or sorry, specific outpatient pharmacies. I've heard of health systems across the country either closing or outsourcing them to different companies to do that work. I think it does a couple things. One, it really prevents you from having that patient contact, and it really prevents you from having that opportunity to really create that ecosystem. And the example I like to use a lot is to think about Apple, right? So whenever you're within the Apple system, things just work. And in my experience, when you have the EHR being the backbone of patient healthcare, you're really allowed to then see the continuum of care and to make sure the patient's receiving the best care across the continuum. So a great example I like to provide. When you look at an outpatient pharmacy, say Walgreens or CVS or name your pharmacy solution, when your EHR sends a discontinue order to an outpatient facility, it doesn't always necessarily result in that order being discontinued. Now, there's progress being made to that end, but when you think about a patient who maybe is a transplant patient, these are complex patients that you have within your facility, and you might be constantly changing their tacrolimus medication. So every order that then goes across doesn't change necessarily the discontinue order. And so a patient may result with a profile that has multiple different orders for the same medication. And so I think that just really highlights the importance for health systems to start thinking not about just providing those inpatient services or those services that a patient might access once or twice in a lifetime, and really start to ask the question, how do we become all encompassing? And I think when you look at the market specifically and you start to ask the question of what is the market doing, you quickly start to realize that competitors in the outpatient market are starting to march towards the inpatient world. And there's going to be this kind of crossroads that I think will happen in healthcare over the next short bit regarding how care is going to look. It's going to be very data driven. It's going to be very patient centered and patient focused and patient centric from the sense that it's not just the patient anymore, but it's also a consumer or a customer of care. And so I think pharmacy leaders need to be asking the question, how do we change our modality from being somebody or a service that is waiting for products to come to us to a service that is asking, how do we go after and meet the patient where they are?
Yeah, well said. I think you mentioned your specialty pharmacy too. And I think that's a great example of a lot of the things that you just spoke to, because I think what we're seeing across the country is, some hospitals are outsourcing retail specialty to major retail chains. And also some hospitals are very hesitant to get into or expand these service lines against commercial competition. So, why do you really think hospitals shouldn't be afraid to compete in these areas?
Yeah, that's a great question. I mean, I think the easiest thing I can always say is it's uncertainty of the unknown. Kind of, you alluded a little bit to that of, well, if I don't know how to do this, or if I don't have the specialty knowledge there, I'm just going to ask somebody else to do it. I think there's perhaps a one or two case use that has the need for an outsource, which that's really when it comes down to contracting. If you're out of network for many of the organizations that are, or the insurers that are coming and having patients within your facilities. But I think that's a short-term fix, and really you need to work within your hospital and your health system to work with the payer group to make sure that you become in network for some of these insurers. I think after that, you just have to realize that much of this is just like a joint commission or board of pharmacy inspection, right? There's a checklist. You have to meet the checklist. It's as simple as putting together an Excel spreadsheet with a plan and to start to work through the checklists that need to be done. Interestingly enough, I think when specialty first came out about a decade ago, a decade plus, a lot of people didn't know what exactly specialty was. And so I think it was very easy to just say, well, I don't know what this is. I'm just going to hand this off to somebody else and I get some revenue from it. But I think as that service line has evolved and developed over the last decade, we now have leaders from across the country who are experienced in that specialty realm. I think that when you look at this from a patient-centered and provider-centered perspective, again, having that within your organization really enables you to have that transparency of care and to be able to coordinate that care. And I think that that's really the missing part of patient care here in America and perhaps around the world, is that we want those quick interactions that maybe drive the revenue, but we forget that really the patient is the one who's going to drive the value or extract the value from that relationship. For myself, I know that our specialty providers and our physicians speak much more frequently than they do with an outpatient pharmacy. When you have internal resources like email, the in-basket message for EHR, or even tools as simple as the Microsoft Teams or Zoom or Skype, where you can quickly message somebody, you get the results a lot better. And so I think having that internally to you really starts to drive the benefit to your organization that I think health system leaders need to look into. Subsequently, I think a lot of people get scared of the sheer amount of cost that comes as a result of specialty pharmacy drugs. These are medications. These are not cheap medications quite regularly. They're tens of thousands of dollars. And I think it starts to spook people when they see their drug budget have this spike. And oftentimes when I've encountered this in my career, I often have to remind our finance colleagues to also, draw their finger down and also look at the revenue line as well. And it's covering that expense. And I think that really then drives the value and now the value benefit of that specialty pharmacy model. I think there's also something to be said about that model in normal care for an outpatient provider. Again, I think inpatient's pretty well defined about the value that the pharmacist provides. But in the outpatient realm, we're starting to see a lot of physicians who practiced with pharmacists to start to ask for that relationship or ask for that resource in their clinic. And I think if we are able to establish that clinical presence in the ambulatory world, and again, I divide pharmacy up into three buckets. I think of it as inpatient, I think of it as ambulatory, and I think of it as outpatient. I think ambulatory is that missing section that really starts to drive the benefit of that transition from that high acuity to that lower acuity while still maintaining that relationship with that specialty or outpatient pharmacy. Again, I think as we talked about earlier too, one of the big things that's happened is if you keep track of the news, you're seeing insurers starting to buy the pharmacies, who are then starting to buy the providers, who are then starting to provide or to purchase hospitals. And so you see this steady march from that end product into the care realm. And I think that's kind of a canary in the coal mine for healthcare to start to wake up and to realize, hey, there's an opportunity here that we may not be taking full opportunity of, especially if you're a 340B organization. Those are opportunities that are intended from a federal level to help spread some of the scarce federal dollars and make sure that we are able to support the care that's happening on that inpatient with that offset from outpatient. I think one of the big things where pharmacy we need to push in that realm is also has to do with the fact that when we are using 340B, we're actually not taking taxpayer dollars. This doesn't cost the taxpayer, doesn't cost the state anymore, but it is providing a service for the community and for the patients and helping expand resources that otherwise would not be able to be supported by a health system.
Yep, exactly. I want to pick up on the outpatient and ambulatory that you mentioned. Obviously you have the challenge of a lot of clinics spread over a pretty big geography. How do you look at or approach providing services to that geography?
Yeah, that's something that we're having to overcome. I mean, I think the current answer that we are pursuing is similar to many others in the country, which is basically a mail order service. We've started to mail from our pharmacies more regularly and to start informing patients that we have that. But I think that when you look at the market, it's shifting, right? So the example I like to give is we have a new generation of health consumers who are coming out and expecting a similar experience to that of ordering online and having things shipped to their door. So I think that having that mail order function is definitely a priority. But in my perfect dream state, I would actually really like to have the patient not come to the pharmacy at all. And so what does that mean? That means we need to start looking towards drone technology. We need to start looking at courier services where the patient just gets a call as that shipment is arriving saying, hey, I want to talk to you about your medication. How could we use some tools to get that interaction, meeting the board of pharmacy requirements, but helping the consumer understand that they are just a phone call away from that help. I think if we don't do that, I think there's organizations out there, such as a company just up the I-5 corridor from where we sit up in Seattle, who's trying to figure out how to bridge that gap. I call it the last mile delivery problem, right? And I
Right.
think there's a lot of people there who are really working on getting that medication to that endpoint. I think where health systems have a unique niche is that we can provide that more brick and mortar customer service. That if you need something more urgently, we're here, but we're also going to provide the care where you are. And I think again, having those services, having a mail order, having a courier service, having some drone technology really needs to be on the roadmap for most organizations as you're looking towards the future.
You looking at linking those services to any particular population health initiatives that you guys might have going on?
Yeah, that's a really good question. So the short of the answer is yes. I think what we've seen in the outpatient realm and specifically the retail realm of outpatient, we've seen a steep decline in independent pharmacies who really serve communities within the city and hard to reach spaces out in the rural setting. I think one of the things that has also happened as a result of that is suddenly as costs have gone up and profitability of these retail stores have gone down, they've closed. And that's leaving vast pharmacy deserts where you don't have access to care. And for some of these patients, they may not have access specifically to come into the hospital to get their medication. So being able to drive the medication out there to patients who may not have that transportation issue is definitely a big part of it. That's kind of more from a DEI lens. But then I think when you look at that DEI lens and you look at the population health lens, we often see that patients who are struggling with some of their disease management, they just don't have access to medications. And we know from studies that if patients are on their medications, they will actually be able to better their health. And so I think when I look at this, I look at how can we manage a population? How can we manage diabetes? How can we manage cardiology better if we have better access to medications? And so, because this isn't some of the diseases that end up coming as frequent flyers into our EDs aren't necessarily complex or new diseases to healthcare. Diabetes, heart failure being two that are constantly on my mind. We have medications that can help manage it. So the question then becomes, how can we use these services, specifically with our 340B savings, to drive programs that can reach these patients and help better use the precious healthcare resources that we have within our health system?
Yeah, I think that's so important. And it's also a key contributor, which really surprised me that it was as much as it was to 30-day readmissions. When I was in practice, we did a fairly detailed study. We looked at what was driving our 30-day readmissions, and shockingly, 36% of them were medication related. And most of those were completely preventable if we would have captured that prescription and we would have proactively made sure that we headed off all of those reasons why the patient wasn't taking those medications correctly.
Yeah, no, I couldn't agree more. And I think it just highlights the interconnectedness that we have when it comes from that continuum of care on that inpatient side. to really make sure that the providers upstream realize the impacts of helping drive that prescription to your discharge pharmacy. I think for me personally, when I think of when a patient leaves with the medication in hand, it's easier for my ambulatory pharmacist to follow up with them and ask them, do you have any questions? Are you taking those medications? How is your edema working, or how's your edema right now? Do you need additional medication? Do we need to titrate more? And I couldn't agree with you more, Jim, that really helps keep patients at home.
Yep. As a multi-hospital system, I think you probably face some different challenges than single facilities. How have you organized your pharmacy enterprise to be most successful across the various hospitals and clinics that you're supporting?
Yeah, so I would put the construction in progress sign on that. I think it's ever evolving. Structurally, we are designed in a shared services and site based team, and I use those words carefully because I actually, when I got here, we were termed the system and the sites. And I wanted to change my mental model around that and change our team's mental model around that this really isn't a system versus a site conversation. It really shouldn't be an us versus them. So we changed the system resource to shared services because a fraction of my FTE is paid for by every one of our hospitals. A fraction of our compliance team is paid for by every one of our hospitals. So we wanted to change the mindset around this, that this wasn't an us and them, it's just an us conversation. So when we did that, we looked at our shared services and we split our team, or at least mental model for me, I split it into three major divisions. So we have one director who is in charge of our ambulatory services. We have one director that's in charge of our outpatient services. And then we have 6 directors that are in charge of all of our different hospitals and inpatient settings that are within the community. And as a result of that, we have actually created an alignment around the directors of, depending where a problem lands, there's always a leader there who can take that from a service line level. At the shared service level, we have a little bit different structure where we have our medication safety officer, we have our quality regulatory director, and then we have our pharmacy business director who's in charge of purchasing 340B and informatics. And then we are also, that person's also acting as the clinical director, as well as we are doing a little bit of remodeling within the department. And I think that creates a little bit of collegiality around how we solve problems, right? I think it's very important from a health system that everybody can speak to one another, that we have the clearest lines of communication, and it doesn't always have to run through me. And I think my team has just naturally found that rhythm where they're able to function at a very high level. I'm very blessed by my team. I think they are just a fantastic team and work very well together. But I think it also helps create the sense that we're all in this together. We're all one. And so a great example with our quality team that we developed here, we have a group of technicians that really do a great job of running our quality program. They're constantly going to different facilities, doing some of our employee monitoring and our environmental monitoring. We're working towards checklists now to start helping make sure that we're in a constant state of readiness. But having that shared resource, that system resource that can float and ebb and with the needs, really has been, I think, vital to our success. I think subsequently at the site level, we have tried to standardize that structure as well. And standardize may be a bad word for some, but I look at it as having a consistent way of getting things done. As an executive, it's hard to go to be with the other executives at our organization and say, well, at this site, this is how this is done, but at this site, this is how this is done. And so really having a strong leadership team with those directors really allows them to start to standardize how we practice and be able to move. But I think, I think having that good core group that can help lead, I think is the right way for an organization to structurally set up. And again, going back to your comments about the outpatient, or your questions about outpatient, I think one of our one of our successes as a health system is really to put one leader over that and start to help drive service line rather than specifically looking at hospitals or separate organizations individually.
Yeah, I think it's exciting that we're seeing a lot of interest in that whole concept of shared services across the country now. I think, a lot of these organizations got big quickly and they did kind of the easy stuff like HR and IT and purchasing, but it took them a while to get down to some of the more complex initiatives like pharmacy. So yeah, it's great to see you guys taking a leading role there.
Yeah.
Also, speaking of talented staff, I note that one of your facilities was recently named as the third facility in the country to achieve ASHP certification as a center of excellence. So, tell us a little bit about that journey and why you and the team decided to take that on.
Yeah, so the team at that facility was definitely passionate about that work. They were very interested in pursuing this and jumping into the deep end, if you will, as a part of the accreditation effort. They did a lot of the work running through the checklist, making sure that they were helping push the organization in areas to improve on. And I think we'll be looking at this as for our entire health system down the road in the near future, as a lot of the metrics apply across the board. I think a large part of this had to do with just their desire to highlight all the good work that they're doing, right? And I think we all know in our health systems that we have fantastic leaders and fantastic healthcare providers with pharmacists and technicians who are excelling in their specialty, and this was just an easy way to kind of to check the box that yes, we are doing the right thing. We are doing the right work, and for ASHP to help recognize that. Again, as I said, I think the challenge with this and with all these new initiatives or new projects we have to do is really start to look at that checklist. And I think one of the things that they were very successful with in the COE work is to actually look at this as a residency accreditation, where they had an Excel spreadsheet, constantly working with here's the standard, here's how we interpret it, here's how we meet it or don't meet it, here's what we need to do to meet it if we're not. And I think that they were just very organized. So specifically, just a shout out to Ryan and Kate up in that site and their ability to get that organized and to be able to move that forward. I think they did a fantastic job. And again, I think a leading example for the rest of our health system to follow.
Oh, congratulations, because I know it is a lot of work and well-deserved recognition. Your area of the country, I think, like a lot of places, faced some pretty significant challenges this past year in terms of recovering from that triple-demic of COVID, RSV, and the flu. How'd you position pharmacy during this time to be the major contributor that it was to weathering that storm?
Yeah, that's a great question. I think initially, pharmacy was seen kind of as an ancillary service, right? Like we'll get to them when we need them. And if there's anything that anybody takes out of this podcast, one of the things I would love is that as a profession, we push back on the term ancillary. First of all, I don't really believe that anybody's ancillary in healthcare, but specifically medications. We touch every patient who comes into our facilities, who comes to see for a procedure or whatnot. So I'd love to just say that I think we put our stake in the ground to say we're not ancillary. We are pivotal to this organization's success, to the care of our patients. And I think standing up and willing to raise your hand, I think was one way that we were very successful in being able to engage with our leaders. I think it didn't hurt that the vaccines had to come through us for COVID, so that really helped put the spotlight on us. Helped highlight just how complex it is to move medications according to regulatory standards, especially when we were in the emergency use situation for the vaccines and being able to maintain that. We actually did a joint citywide with other health system distribution, vaccine distribution hub during COVID, where pharmacy was one of the large drivers for this mass vaccination center. At one point, I believe we were the third or the fifth largest vaccination center in the country. with just the throughput. Now, we couldn't have done it obviously without the nurses and the physicians and anybody who was coming and vaccinating, but the sheer production side on the backside really highlighted, I think, to many in the city, just the volume that pharmacy was able to produce and the leadership that you have. I think the other thing too that's happened with this is that we've been able to highlight where pharmacy is at the intersection of healthcare, business, and quality and safety, right? And to be able to drive that conversation from a higher level, once you're in the room, you can hear the conversations. You're able to start to leverage those three skills in your arsenal, in your belt, to help start driving value to the patient, to your administrators as well. So I think really having that outward perspective of, hey, we can fix this, is really valuable when it came to our health system leadership team. The other thing I think that really we, as a profession, we need to start looking at is we have two brains, right? So I challenge myself and challenge those around me to really look at, do we have that? Are we using our pharmacist brain, or are we using our leadership brain? And the pharmacist brain, in my mind, is that perfection, right? And it starts from that first day of patient care lab, where we are given a prescription and told what's wrong with this prescription. And from then, we're always looking for what's wrong with a prescription. And sometimes I think when we're in those leadership positions within an organization, we sometimes want to have that perfection, that analysis, and it really slows us from being able to use what I call the leadership brain. And I think that leadership brain is really something that as pharmacists, as pharmacy executives, we have to start developing, where we're not necessarily looking for the perfect solution. We're looking for a solution that we just need to implement and come back and check and act on that. And so I think within the triple demic and having some of this constant change, we were really starting to lean into that. Hey, this is the answer that we know we have the information for today. We're going to implement it, and then we'll come back and look at it. Now, there's a danger in that too, right? Because it conflicts often with that we want perfection, and so there's a balance to be had between those two. But I think when we start to get into those circles where executives are looking for solutions, we're not always going to have that measure 100 times and make the one cut. It might have to be just measure twice and do the cut and see where we are. And so I think being willing to take some chances, I think, is really an important skill with the triple demic that helped us survive.
Yeah, well said. And I couldn't agree more on losing that ancillary support service terminology. Whenever I have the opportunity to interact with C-suite personnel, I always try to emphasize the fact that pharmacy is well past that designation. And it really is a strategic resource and strategic asset that needs to be considered and managed as such.
Yeah, I couldn't agree more. When you look at the Bureau of Labor Statistics and you look across the country, there's roughly 3 million nurses in the country. There is about 900,000, let's round it up to 1 million. And there's about 300,000 pharmacists. And so you have like a 9 to 3 to 1 ratio as a pharmacy service line to a nursing service line. But I was speaking at a conference just this last week and speaking to many of my colleagues across the country. Pharmacy is quickly growing up as a financial performer in each organization, and in some organizations across the country has actually become the bottom line, surpassing surgery. And so I think that's not the definition, as you said, of what an ancillary service is. And I think really opening the C-suite, if you will, to having a chief pharmacy officer, and I think there's even layers within the C-suite that really need to be discussed, that the pharmacist is sitting at the decision table and helping the organization discuss, well, if we make this decision or that decision, here's the outcome that we will see in pharmacy, which impacts our bottom line. I think being able to have that conversation is an important part of our professional growth as well.
Yep, absolutely. You mentioned you have 500 plus staff members. How are you approaching education and training, both for your staff as well as undergraduate and postgraduate?
Yeah, that's a hard one, specifically around that, because coming out from the pandemic, we're still in a recovery state. And so I think to really expand some of our service lines has been something that we've been wanting to do for a while, but have been just financially challenged as an organization to support that. I think it's no surprise. I think it's been spoken about quite a bit about the shortage of pharmacists and technicians that we're seeing. And I think it's a little bit of a warning to us. When you look at how we've portrayed pharmacy, we've portrayed it as a negative, or healthcare in general as a negative. Like it was tough in healthcare, it's still tough. And I think we need to start changing that narrative. Specifically within our department, I think what we've tried to do to change that narrative is to try to get some more CE credits, to try to get some more interactions with the College of Pharmacy within our area. That comes with its own trade-off. We don't always have a bunch of staff that can necessarily educate and train. And so a lot of it has become developing tools that are self-taught, or tools that we can use within our training system to be able to move initiatives forward. I think we're still in our infancy in a large part of that, but seeking to grow that as we move forward. At the same time, our team's been kicking around ways how we can increase some of those technician training opportunities, and we've kicked around whether or not we can open a school or a technician training school. That's something that I think is in maybe our roadmap, our 5 to 10 year roadmap, specifically looking at training and growing our own. We have a really strong residency program, and we end up retaining quite a few of our residents, so that helps. But the question becomes, how do we maybe take somebody in food services or environmental services who are looking for a career growth within healthcare, and how do we bring them in to train them and to bring them up to that level? I think it's got to be one of those solutions where we're growing our own and able to then fill our team with those people who have already demonstrated their commitment to the organization. But I think as we move down the road, clearly would love to expand our residency training program. I think working in a multi-hospital health system, we've got everything from a burn unit to a psych unit to a children's hospital to rural to critical access. And so to be able to move within a system and understand how pharmacies practice in a health system at different levels within a region, I think is a really unique learning opportunity that we can provide here. But I think currently our focus, as we've kind of talked previously, is really around the financial recovery right now and being able to move that forward.
Right. You mentioned staffing. What else would you say are your probably your top 2 challenges that are facing your pharmacy right now?
That's a really good question. Top 2. So I would say there's probably the number one. Again, we're trying to be that driver of revenue at the bottom line. I think previously within my organization, pharmacy had not taken an aggressive stance, or I've had some folks here mention that they've never had a pharmacy leader who's willing to talk about revenue and generating revenue with that. So I think slowly we've changed that perception and really started to push the organization to try to see pharmacy as a bottom line contributor. So much so that in the last month or so, one of the finance leaders said to me that pharmacy is really the star of this fiscal year. Like, you guys have really done a good job of turning a profit and being able to turn on programs and see that revenue stream come in. I think with that comes the accountability, though. And so I think that's kind of the second opportunity to grow. As we try to grow together as a health system and become stronger, we firmly believe that wherever you go in our health system, you should receive that same level of care. We've recently replaced our automated dispensing machines, which have not been looked at really for 15 plus years. And really, that's just kind of opened the opportunity for us to start to standardize how inpatient care is provided, which has resulted in some savings as well. And so when you look at that revenue generation, on the inpatient side, we're kind of a fixed revenue reimbursement. So it's about lowering costs. On the outpatient, it's about increasing service and increasing revenue stream. And so we're applying pressure in both ways as a department, and starting to see that results that we're looking for.
Well, this has been great. And, I want to be respectful of your time, because I could probably keep going and talking to you for the rest of the day. But any last words of encouragement or advice for our listeners?
Yeah, I think we are in healthcare right now. We are in a difficult chapter. In my 15 plus years of experience, I see healthcare going through cycles where you have highs and you have lows, and I think we're coming out of the lows that we've been in during COVID. But I think we also need to not be afraid to raise our hand and volunteer for those leadership opportunities within our health systems, and really start to ask the question of what more we can do for our patients. When you put the patient at the center, when you put your team, your employees at the center of all the decisions that you make, you end up winning. And I just can't emphasize that enough. That as healthcare leaders and as pharmacists, it really comes down to our people and our patients, and to just keep our focus there.
Dr. Majid Tanas, thank you for being a guest on the Pharmacy Innovators podcast, sharing your career work and on thoughts on where you see things heading in the future.
Thanks for having me, Jim.